Imagine waking up, opening your eyes, and realizing the vision in one eye has simply vanished. No pain, no warning, just a sudden, dark blur where your sight used to be. This is the hallmark of a central retinal vein occlusion, or CRVO. The eye's drainage pipe, the central vein carrying deoxygenated blood away from the retina, has developed a massive clot. The outflow hits a solid wall. The mechanics of this are brutal and immediate. The arteries are still pumping fresh blood into the closed system of the eye. Because that blood has nowhere to drain, extreme vascular congestion sets in. The pressure inside the retinal veins rapidly spikes. Eventually, those delicate vein walls reach their breaking point. They rupture, spilling plasma and red blood cells directly into the surrounding, highly sensitive retinal tissue. This structural failure forces the retina into a state of active trauma. It is drowning in its own fluids, requiring immediate medical triage to prevent total loss. Everything hinges on one question: non-ischemic or ischemic. The non-ischemic pathway is milder, the retina is relatively clean, and tissue survives. The ischemic pathway is a direct medical emergency, smothered by extensive hemorrhages and white cotton wool spots, literal zones of dead tissue. To prove the extent of the damage, doctors use a fluorescein angiography test. They inject dye and watch it flow through the eye's vessels. In an ischemic CRVO, this scan reveals massive dark zones, areas greater than 10 disc diameters across, where absolutely zero blood is flowing. An ischemic diagnosis demands an immediate shift in clinical focus. It marks the start of a high-speed race against irreversible tissue starvation. The most surprising part of a CRVO is how the body actually responds to it. Medical intervention doesn't go in and dissolve or extract the original clot. That central pipe remains permanently blocked. Instead of fixing the broken pipe, the eye attempts to construct an entirely new plumbing system to bypass the disaster area. This biological engineering project takes several weeks to complete. The eye taps into existing microscopic capillaries known as venovenular collaterals. Because the main route is dead, the mounting blood pressure forces these tiny, thread-like vessels to rapidly dilate and stretch far beyond their normal capacity. These expanded collaterals eventually connect different branches of the venous system together. They bridge the gap right around the central clot, establishing a functional, albeit inefficient, alternative drainage route. Without any outside surgical help, the eye successfully architects its own custom bypass to stave off complete and immediate destruction. Once those collateral vessels take over the drainage workload, the pressure drops, and the spilled blood and fluid trapped in the retina can finally begin to clear. This chart maps out that clearance process, tracking hemorrhage volume against time. The slope of this line shows a painstakingly slow biological process. Small intraretinal hemorrhages resolve spontaneously at a rate of roughly 1% per day. Looking at the full timeline on the x-axis, the sheer scale of the recovery becomes clear. Resolving the acute phase of an untreated venous occlusion requires a grueling 6 to 18 months of natural healing. For a non-ischemic eye, this slow-motion recovery works. The patient waits, and the blood eventually clears. But for an ischemic eye, this long timeline masks a ticking time bomb. While the newly built collaterals are decent at draining away excess fluid, they fail at delivering adequate amounts of fresh oxygen. The ischemic retina remains severely starved. In a state of prolonged suffocation, the retinal cells begin pumping out a chemical alarm known as VEG, or vascular endothelial growth factor. High levels of VEG trigger a condition called rubeosis. The eye frantically tries to get more oxygen by aggressively sprouting brand new, highly chaotic blood vessels across its interior surface. These rogue vessels are structurally unstable. In about 50% of untreated ischemic cases, this tangled web of new tissue physically creeps into and blocks the eye's main fluid drainage angle. This causes a catastrophic spike in intraocular pressure within 2 to 4 months of the original clot. Clinicians call this the 90-day glaucoma. The eye's chemical attempt to survive oxygen starvation produces the exact pressure spike that destroys the remaining vision. To prevent this destructive end stage, ophthalmologists launch an aggressive counterstrike against the VEG of alarm. They use targeted injections of anti-VEG medication, intravitreal steroids, or precisely aimed laser therapy known as PRP to physically neutralize the chaotic new vessel growth. None of these treatments are designed to cure the original central vein clot. Their sole purpose is to shut down the rubeosis and stop the eye from blinding itself before the 90-day deadline hits. But resolving the local emergency is only half the battle. A massive vascular blowout inside the eye doesn't happen in a vacuum. It acts as a glaring, localized warning siren for dangerous systemic issues throughout the rest of the body, like uncontrolled hypertension, diabetes, or severe cardiovascular disease. Surviving a central retinal vein occlusion requires defeating the crisis on two fronts. The patient needs urgent, ongoing intervention to protect the eye from its own defense mechanisms, and comprehensive systemic management to ensure the next clot doesn't strike somewhere far more lethal.